All right, so this is my third year coming to Stowe, and I have to admit that it's actually one of my favorite conferences that I get to come to. We have awesome speakers here. There's some kind of cutting-edge stuff. And so you're probably wondering, why in the hell am I up here talking about a disease such as anaphylaxis that nothing's really changed over the last 30, 40, 50 years, right? We don't have any new fancy drugs for it. We don't see any articles in our medical literature highlighting some diagnostic approaches. And even though this is made up, I feel like this is an actual response. So when asked if he could describe the novel approach, Dr. Weimer-Scheimer replied, "Fuck yeah, I just grabbed a probe, started looking for B lines in the patient's trachea." And that's how we diagnose anaphylaxis. So really the reason that we're talking about anaphylaxis is, despite it being kind of true emergency medicine, right? Acute presentation, potential for life-threatening factors, and a quick turnaround time, really, if we do the right thing. Despite all these things and us seeing this pretty commonly, we still manage to mess it up. So some studies have shown that over 50% of patients who present to the ED with anaphylaxis have been misdiagnosed. And this is either treating them as an anaphylactic patient when they don't have it, or not giving them the appropriate therapy when they do have anaphylaxis. And even when we do manage to diagnose it, we don't always give the right therapies. And so epinephrine, right, the first-line treatment, life-saving medication for anaphylaxis, this was a review from a UK database over a couple decades. They found that epinephrine was not administered in 14% of the cases where patients went into cardiac arrest, and only about 60% of the patients received it at some point during that arrest, right? So let's start with diagnosis. Who recognizes this? No hands, wow. So this is the World Allergy Organization guidelines and definition for anaphylaxis. They kind of have it up into 3 columns. You have, different time frames. There's different numbers of systems. You have to have one system or another system. This is confusing, right? It's hard to remember, and this is probably what's contributing to some of that misdiagnosis. As ED providers, all you guys really care about is whether or not the allergic reaction is severe. It doesn't matter how many systems are involved, it matters which systems are involved, right? And so really, if there's a problem with your A, B, or C, your airway, your breathing, circulation, give epinephrine, right? This is our life-saving first-line therapy. It's an alpha agonist that leads to our vasoconstriction, decreased airway inflammation, helps with our hypotension and shock. The beta agonism, so beta-1 agonism, increases our chronotropy, inotropy to increase our cardiac output. And then the beta-2 agonism can actually help with some of that bronchodilation and prevent some of the inflammatory mediators from being released from our mast cells. And it's very important that we give epinephrine early. So studies have shown that food-induced anaphylaxis, the median time from food exposure to cardiac or respiratory arrest is 30 minutes. For insect envenomation, it's half of that, 15 minutes. And for medication-induced anaphylaxis in the hospital, it's 5 minutes. That's not a lot of time, and so it's very important that we give our epinephrine early and we give it in the appropriate dose. Speaking of allergies, I love looking at patient allergy lists. Does anybody see? There's an interesting allergy that this patient had to tetracyclines, which was rigor mortis. So be careful with your allergy list. That's a side point. These aren't always accurate. Here's our dose, right, for adults. 0.3 to 0.5 milligrams intramuscularly. If you have an exact weight, there is a weight-based dosing, 0.01 milligrams per kilogram, and this is what we should be using for our little kids with a maximum of 0.3 milligrams. The reason that we give it intramuscularly is because we're much more likely to cause an adverse cardiac effect or overdose the patient when we try to give it an IV bolus. And I know there's a lot of literature out there. This is a completely different talk of using push dose pressors and stuff like that. They've looked at this retrospectively. We're about 8.7 times more likely to cause an adverse effect when we try to give it IV, and over 61 times more likely to overdose the patient. So don't mess around with the IV. When they come in, give them the IM first, and you can worry about starting an infusion afterwards. A quick note about ratios. So as of May 2016, about a year and a half ago now, USP released a statement saying that they are eliminating the ratio expression for epinephrine, right? So historically, we always hear epinephrine 1 to 1,000, 1 to 10,000, 1 to 100,000. The ratios are now gone, and so every epinephrine product that you have in your hospital now should be expressed as a metric concentration. So for our anaphylactic kind of IM dosing, we should be using the more concentrated 1 milligram per ml strength. And then our cardiac epinephrine, previously the 1 to 10,000 is now 0.1 milligrams per ml. And this is because there's been a ton of med errors associated with using that ratio strength. There's really no other drugs out there that we use this for. Does injection site matter? Does it matter where we give these people the IM injection? And in fact, it does. This is a really cool PK study that was done in healthy adults, not adults with anaphylaxis, but they gave everyone a intramuscular dose of 0.3 milligrams of epinephrine, and then they kind of compared the plasma epinephrine concentrations that you see on the vertical axis to time on the horizontal axis. And in the yellow and orange, you see EpiPen into the thigh and just intramuscular epinephrine into the thigh. And then in the lower points here, we see our sub-Q dosing. And what's interesting is that when we look at epinephrine given IM into the deltoid, it's actually comparable to placebo saline, right? So we should be giving all of these patients our doses, or their dose, in the anterolateral thigh. All right, we talked about site. Does size matter? Who knows where EpiPens got their, or determined their needle lengths from? Anybody? So it comes from military data, actually. This goes way back to the 1970s, and the military was looking for antidotes for soldiers in chemical warfare, right? So they developed the Mark I kit. A couple people familiar with that? So for your nerve agent reversal. And they had to take into consideration that these soldiers are going to have thick pants on, and they're probably going to have these thick chemical suits. So they said, well, we need a needle length long enough to penetrate both of those, so why don't we use 2.2 centimeters? So that's what they picked. I have no idea. No one really knows where the EpiPens got their needle lengths from. And the problem that we're seeing is that with the increasing epidemic of obesity, not only in America, but in the world, some of these patients and a lot of adult patients may be at risk for that needle length not being long enough. And they've studied this. There's 2 different studies in adults where they actually took an ultrasound and they measured the skin to muscle depth. And so the figure on the left is actually uncompressed with the probe, and the figure on the right is compressed. You have to have about 2 to 8 pounds of pressure to release or to trigger that epinephrine needle to come out. And what they found was anywhere from 19 to 31% of patients had a skin to muscle depth that exceeded the length of epinephrine autoinjectors. So this is a big problem. Patients with greater BMIs are at higher risk, and women were actually almost 6.5 times more likely than men to be at risk for having that needle not be long enough. So this is something that we need to consider. Patients who arrive to your ED who have already gotten a dose of EpiPen at home may not have, in fact, actually got any epinephrine on board because it may have been a sub-Q injection and they just didn't absorb it. Can the needle be too long? In adults, probably not. There is a pretty big case series of about 22 cases of lacerations and other injuries involved in pediatric patients with EpiPens. And of 22 of these, 4 of the EpiPens were actually stuck in the patient's limb. And when they kind of evaluated these, you can see they actually took a radiographic image of the Epi autoinjector, and the needle was bent. And so what happened was it goes in, it hits the bone, and then it creates almost like a fish hook, and these kids get these crazy lacerations from trying to pull the needle out. And so inadvertent administration into the bone can be detrimental. This was my favorite here. I'm not sure if the person administering this was trying to give an IO injection, but that's the patient's tibia there on the left. So that is not where to inject our autoinjectors, so don't do that. Is there an ideal needle length? We don't really know. The CDC has recommendations for vaccinations into the deltoid and the thigh, and these are kind of their recommendations. However, it's really hard to extrapolate those over to our auto-injectors because we have to remember that the auto-injectors do have that pressure applied to it, and they also have a propulsion force of about 23 pounds when that needle comes out of the syringe. And so I think these are fairly safe to extrapolate if we're drawing up the epinephrine from a vial or an ampule and administering it from a syringe. And then not to mention the insane price increase after Mylan purchased EpiPen. So back in 2007, the cost was around $100. This is almost 2 years out of date now, and so the cost is probably closer to $800 per EpiPen, which is ridiculous given that this has been around forever. All right, so you have your phones ready. So first question, are you less likely to administer epinephrine to older patients? So just go into that text box and you can either text A or B. So looks like the majority is saying no. So we've studied this as well, and this was a retrospective study of about 2,700 patients, and about 500 of those had anaphylaxis, and they compared groups of patients who were less than 50 and those patients who were older than 50, and what they found was that patients less than 50 years of age were much more likely to receive epinephrine than those who were greater than 50. And I think this is kind of that inherent worry that we all have in the back of our minds. With that patient, maybe they have a history of cardiovascular disease, they had an MI a year or two ago. But most of these patients in the elderly group, even if they got epinephrine IM, the rates of adverse effects were extremely low. In fact, when we give a 0.3 milligram dose, your plasma epinephrine concentration is going to be about the same from heavy exercise. So essentially what we're doing is we're just giving these people a stress test, right? And most of these people, if they do have an adverse event, it's going to be a temporary trope bump, maybe some angina or something like that. But it's very uncommon to have a severe adverse reaction from IM epinephrine. So we need to make sure that we're treating these patients appropriately if they do have anaphylaxis, right? There's no absolute contraindications to epinephrine, so age should not be a reason not to give it. So what do we do when our IM dose doesn't work? We can give another one. You can repeat every 5 minutes. Typically, after about 2 doses, we should start to be transitioning to IV epinephrine, right? There is a concern that with this massive vasodilation going on, maybe these patients just aren't absorbing that epinephrine from the IM site. And so what the guidelines recommend is an IV infusion of 1 to 10 micrograms per minute. You titrate to hemodynamic effect. What do we do if they're not responding to IV epinephrine, or we've given them several doses of IM epinephrine and they're not responding? What questions should we be asking, specifically with home medications? Yeah, are they on a beta blocker? So there's some evidence out there, this is really limited to case reports, but some evidence to show that patients on beta blockers may have a little bit of competition with that epinephrine. And so if we give them glucagon, we can potentially bypass that beta receptor, increase the cyclic AMP in the cells, and ultimately increase our inotropy, chronotropy, and try to resolve the shock that's going on. But very low quality of evidence. And then we have to remember nausea, vomiting, very common with glucagon, especially in these larger IV doses that we're administering. One more question for you. How long do you observe most anaphylactic patients in your ED after you treat them with epinephrine and their symptoms resolve? So less than 4 hours, that'll be A. 4 to 6 hours, B. They come in, you give them a dose of IM epinephrine, and they get better, and now they're just sitting there looking at you. All right, so this is actually pretty interesting because I posted this question via Twitter a couple weeks ago, and the results are essentially the same as what everyone just answered in the room. So the majority of people, 4 to 6 hours. Some others, 1/3, depends on the patient, 1/3 less than 4 hours. So why do we keep these patients? What are we worried about? Yeah, so biphasic reactions, right? And so this is a patient who comes in, they're looking like crap, we give them epinephrine, they get better, we discharge them, they leave. Historically, the classic teaching is that 3 to 20% of these patients will have a rebound or secondary biphasic reaction that could be just as worse or more severe than that initial reaction. So that's why we keep these people, to make sure that doesn't happen. Okay, really the question that we should be asking is how many of these biphasic reactions are actually clinically significant? How many of these matter? So there was a really cool study that they looked at retrospectively about 430,000 patients. They identified 2,800 allergic reactions, of which about 500 were anaphylactic reactions. And of the 500 anaphylactic reactions, how many do you think were clinically significant biphasic reactions? How many of these patients had clinically significant biphasic reactions? Not quite zero, 5 of them. So about 0.18%, okay? 2 of them had a biphasic reaction in the ED at 16 minutes and 3 hours. The other 3 that were discharged, one occurred at 28 hours, one occurred at 35 hours, and the last one at 143 hours, right? So unless you're trying to keep someone for 143 hours in your ED, I'm sure the director is not going to be very happy with you. So bottom line is that clinically significant reactions are extremely rare. We probably don't need to be keeping people in our ED for 6 hours. There's some risk factors that folks have looked at to try to determine who may be at risk. Bottom line, we don't really have a great idea. A lot of these confidence intervals really come close to 1, so we're not sure. To wrap up, corticosteroids, they've been around a lot lately in the literature. We use them to prevent revisits, to prevent those biphasic reactions. We have to remember that the time of onset for corticosteroids is 4 to 6 minutes. So this is not an appropriate acute therapy. We should never delay epinephrine to give corticosteroids. The guidelines recommend 1 to 2 milligrams per kilogram of methylprednisolone. However, all this data is extrapolated from asthma, and it really doesn't lead to improved outcomes. One study looked at this to see if steroids prevent ED revisits within 7 days, and there was no difference compared to placebo, with a number needed to treat of 176 to prevent 1 ED visit. And the confidence interval for this 176 went all the way up to infinity. So really no difference compared to placebo. Same thing with antihistamines. There's a Cochrane review for H1s, a systematic review for H2s that have essentially no literature to support their use in the acute setting. So to wrap up, when in doubt, give the epinephrine. Don't waste time. Severe reactions can happen very quickly. Be cautious with those adults with increased BMIs and females because they are at higher risk for failing that epinephrine autoinjector pre-hospital. Clinically significant biphasic reactions are rare. We likely don't need to keep these patients in the ED for 6 hours. And there's no data to support steroids or antihistamines in the acute setting. Thank you.